Paul and I are really pleased to be here today and on this Curate panel discussion because when you or someone in your family has kidney cancer, new treatments and therapies becomes a really important focus in your life.
Yeah, you've heard from most of these guys today, and I'm really interested to hear what they've got.
It's through this kind of ongoing research that we're going to reach our goal, a cure. And we're lucky to have Dr. Kollmannsberger, Dr. Chu, and Dr. Lawson here today to tell us what's new and upcoming in kidney cancer research and treatment. So we're just going to turn it right over to you.
Thank you very much. So I think obviously I'm a clinical researcher, I'm a medical oncologist, so I will talk a little bit about what's on the immediate horizon and where the whole study landscape is moving, and I'm sure Dr. Chu will probably talk about SBRT and all the fancy toys they have on the horizon, and then Keith will talk a little bit about what's more in the basics. So in kidney cancer, the clinical research has made tremendous progress. Until, as I mentioned before, until about 2004, 2005, we really had nothing in terms of treatment. And then in the last 10, 15 years, there have been 10 or 12 new drugs. And initially it started with what we call targeted agents, so drugs which target a certain mechanism in the tumor cell, such as sunitinib, pazopanib, axitinib. Over the last 2 or 3 years, the field has completely and almost exclusively moved to what we call immunotherapy. And that is really where the field is going right now. We have just started what we call the era of immunotherapy again. And whatever is on the horizon right now goes into this direction of immunotherapy. We already have the first drugs in kidney cancer as standard. That is nivolumab, which some of you may know, that is currently indicated in second line after sunitinib or pazopanib fails. But there's a lot more to come. It will soon move into the primary treatment of metastatic kidney cancer in combination with another immunotherapy drug called ipilimumab. And the one other thing I do apart from GU malignancies is I do early clinical trials, and virtually 90% or more is some form of immunotherapy now. And what all these drugs try to do is basically to activate your own immune system to fight the cancer. What is the attraction of that? The attraction of that is that it actually carries the potential of cure. We've seen that even in the early trials we already have. There is a small percentage of patients which seems to go into a complete remission, and they seem to be durable. We will have to watch those patients longer, but that is clearly where the field is moving right now. Of course, as always, as oncologists, we are pretty simple thinkers. If we have an active drug A and an active drug B, we put them together in a combination and hope that it works better. So we are combining these targeted agents with immunotherapy. We combine different immunotherapy agents. And there is really an avalanche of clinical studies coming down right now. And I'm absolutely certain that within the next 10 years, the field will completely change again. So there's really an incredible number of drugs out there, a lot of them with a lot of promise, and I'm pretty sure that they will change the landscape in the next coming years.
Thanks, Christian. And I'm just going to move on, and Keith will speak after me. Just have a few slides, and Stephen asked me to summarize what the future looks like in terms of the radiation oncology and SBRT specifically for future advances. And just building on what Christian was mentioning, new drug therapies are moving into the RCC space, and where does radiation fit in that? We know that conventional or standard radiation to date, low doses every day, results in what we call the abscopal effect. And by definition, that is when you treat a specific site in the body, we observe a response or a shrinkage of tumors in distant or other areas of the body. We know, and it's postulated, that's an immune-related response. And where does SBRT fit into that? This is just the state of the art. It's a complicated picture that illustrates what we understand both at the molecular, cellular, and physiologic levels, that with conventional radiotherapy on the left, we know that it generates an immune response. But with stereotactic radio treatment, these big, big shots of radiation treatment, we induce vascular damage or endothelial cells which line the vascular system. We basically break them up. And essentially what we're doing is creating a microenvironment super saturated with tons and tons of antigens. And essentially what that may potentially lead to is a super immune response. So thereby, if we combine this type of treatment with the immunotherapies that Christian is highlighting, is that potentially we can further the response of the treatments that we're delivering to mediate the tumor shrinkage across all sites in a given individual. Now, currently there are early phase studies, but it looks like in the next 2 to 3 years we'll start getting some readouts of some of these trials. Specifically, we know that at 12 Canadian centers we have an oligoprogression study combining SBRT with patients who are either progressing or with disease with Sutent. The latest one that's come through is with pembrolizumab with 5 Canadian centers, combining that with SBRT. And then most up to date, although we don't have it in Canada, it's available in the States, I'm not quite sure, it may be coming, is the combination of what Christian had mentioned is IPI with Nivo, but also adding SBRT. Now, that last study is an early phase study, 25 to 30 patients, and hopefully, as I mentioned, we'll be getting some data on these studies within the next 2 to 3 years to potentially understand further the molecular mechanisms behind tumor response in combination with targeted drug therapy. The other issue we'd like to bring up is that we touched upon it earlier, and I know someone had brought it up, I believe it was Arlene had brought it up last night at dinner, was what about stereotactic radiotherapy in the metastatic setting for a patient who can't have surgery? We know in the primary setting, as I highlighted earlier in the morning, is that radiation or stereotactic radiotherapy is a potential option for patients who can't have surgery. Well, potentially, in terms of the metastatic setting, that could in fact be the same thing. And the whole notion of what we call cytoreductive SBRT versus cytoreductive nephrectomy is a concept that's been tested and piloted by my colleagues at the London Regional Cancer Centre, as well as some researchers at Roswell Park, where they have shown that one, SBRT in that setting is well tolerated, feasible, and relatively safe. And in terms of the studies, there actually does elicit immune response both on serologic and pathologic markers. So that's also the future coming for metastatic renal cell carcinoma as well. And then to build on this is the whole notion that someone touched upon earlier today is biological specimens, biobanking. What Keith will probably talk about is collecting specimens so that we can learn at the time of diagnosis, understand how patients respond, as well as how to follow these patients down the road. And the key and take-home message from this afternoon is, in fact, as someone mentioned earlier, is that the participation in clinical trials. The only way that we're able to learn and move the field forward is by enrolling patients in well-controlled, rigorous studies in order to learn and build for the future.
Great. Well, thanks so much again for the opportunity to speak today, and really building on this notion where the field's moving towards is trying to improve upon the response rates in this disease for those patients that are currently not achieving effective responses with conventional therapies. And there's a lot of really cutting-edge technologies which are really coming in vogue now. And really our goal as kidney cancer researchers is really trying to integrate ourselves within these really amazing technologies and try to leverage them and apply them to our own kidney cancer research to improve the disease, of course, that we're interested in. And I really made this point earlier at lunch that we need to move now as biologists away from just profiling what kidney cancers look like, but rather really trying to underpin what vulnerabilities exist as a result of the molecular changes that happen in kidney cancer, as well as the microenvironmental changes that happen in this disease. And really, in order to do this, we're going to need to move not just towards clinical studies, but back into the lab, model the disease, and be able to manipulate the disease. And we spoke, of course, at lunch about this new technology called CRISPR gene editing. This is just one technology that's out there that allows us to start really toggling genes on and off in different cell types in order to really better understand how they function in concert with the actual disease process. And by doing so, we can really start to understand some of these vulnerabilities. So again, we highlighted some of the work being done in Toronto that we've been particularly interested in, which is not just looking at one gene at a time, but doing things on a more very high throughput format where we can systematically interrogate all genes within the human genome. And the approach we've taken is something called CRISPR gene screening, where we're able to take a population of cells, introduce specific genetic mutations, and then map back how those genetic mutations within the cancer cells actually dictate responsiveness or resistance to therapy. So this is, again, stuff we have up and running in the lab, and now we're integrating this with our clinical infrastructure that's well established, and this is what we need to do. We need to start looking, how do we design platforms, how do we talk to each other in terms of on the basic science level, on the clinical level, and integrate things and really get coordinated and organized so that we're able to take advantage of all of the specimens we're biobanking and really move this towards a drug discovery pipeline. So this is, again, stuff we spoke about at lunch. We're enrolling patients into studies where we can take their patient, the tumor, do a very high dimensional molecular profiling, and at the same time build personalized models of those patients' disease, so that if we do find something that's very exciting, we can go back and manipulate it, as I said, understand the function, and then really try to move forward with drug development from that point of view. And then lastly, just to kind of cue things off here as well, we really do need to start making new types of drugs, and there's lots of excitement, as William mentioned, and work being done in this area, particularly immunotherapy. We talked about CAR T cells earlier today. The other type of platform that immunotherapy has been really successful for is antibody-based therapies, where we're able to bring together cells from the immune system and allow, get them to work better in terms of recognizing cancer and destroying cancer, and we're actively working towards this too. And that's it, so thanks.
I think one point I would like to make, because as we sat here, we are speaking about SBRT, we are speaking about immunotherapy, we are speaking about basic science, we speak about surgery. We can no longer see those treatment options in isolation. Kidney cancer treatment is a team sport now. And all of us in our team talk to each other all the time, discussing how we can integrate other options like SBRT or surgery into our overall treatment concept. I think that is a very important part. 10, 15 years ago, it was surgery and not much else. And once we had the first treatments, we kind of treated as medical oncologists. And now we have reached a point where we realize we can and we need to, in order to optimize outcome, all the other disciplines as well, not just in research and moving field forward, but already in daily clinical practice.
And that's very true, and I must say I'm very fortunate to stand back-to-back, side-by-side every Thursday in a true multi-day clinic. I have a urologist, I have Georg Bjornsson standing beside me, and that's how we look after patients. One of the prime examples that I showed with the gentleman who's actually in the room, but I won't say who he is, who has multiple disease sites, and he is in Club Med. He's been there for 4 years, and all it took was a tap on the shoulder. Let's come up with a plan. He's not going to get drug. Let's take care of these various sites. And I must say that it's certainly rewarding from a clinician point of view, but it also allows us to look for the future and how we continue to work together for other patients, and it's really the kind of epitome of a multidisciplinary model, not just for research, but really in the daily activities within the clinic. And in the old days when we used to work in isolation, there's no way we could have a fulsome conversation via phone and now even via email. There's nothing better than standing side by side with your colleague, looking at the scan and meeting the patient in the room at the same time saying, how are you going to make this better, right?
And I think, one of the things that's really being underscored here is this idea of teamwork. And of course, patients are at the center of that too, both clinically, but also in the research world. And I had some questions about how can you as a patient get involved in some of this discovery research. And it's really important to note that just by being present, engaged in the clinical care that you're receiving, you're very much a part of that discovery research that's being done. It's not just about getting enrolled necessarily in a clinical trial, but getting those extra blood samples taken, having your tumor biobanked, these type of things are all amazing opportunities to get involved in research, and we would absolutely encourage that.
The other important aspect of clinical trials, which we have not really talked about today, but I think it is an important aspect, albeit a an aspect which we kind of always avoid to discuss is we live in a healthcare system where we need to justify funding for our drugs. And the way we have to justify that is by presenting our payers with good clinical trials which show that, yes, this drug indeed has a benefit. Now, you can imagine the kidney cancer population. We have about 5,000, 6,000 kidney cancer cases in Canada a year, and only a fraction of that is metastatic. Now, with 10, 12, 15 new drugs in 15 years, there are so many questions which we can ask and have to ask in terms of how to best use these drugs, that it's almost impossible to answer all those questions in clinical trials. On the other hand, our payers usually demand clinical trials from us if we want to have funding for a certain drug. So participation in a clinical trial has lots of benefits for patients, but it also allows us to answer those questions rapidly and quickly so that we can then advocate to get these drugs.
I have a question for Dr. Lawson. We hear an awful lot these days about personalized medicine. I wonder if you could explain a little more clearly how CRISPR screens or genetic editing more broadly can be used to facilitate a personalized medicine approach for patients.
Sure. So that's an excellent question. It's something we think about as researchers a lot, is how do we leverage what we're learning in the lab to facilitate a precision medicine approach, which is really trying to use the patient's molecular information or clinical features to guide therapy decisions. And right now, in terms of this type of technology, we're really at the stage where we're building data resources, and this is all work that's not necessarily immediately clinical right now, but the goal is really to amass a very large data resource such that we can go back in and start to make these associations between what are the molecular features of a tumor, map what consequences and vulnerabilities arise as a result of those, and then in the future we could make some hypotheses and test those in clinical trials with respect to personalized medicine. So I think the way to perceive this type of research right now is we're making an investment for the future because we need to learn a little bit more about how this molecular features associate with vulnerabilities. And then really I think moving forward in the coming years, it's going to be taking those things that we've learned and testing them more prospectively.
I have another question. This one's for Dr. Chu. I think often therapies aren't combined, and when a patient is on a TKI, they are often asked to come off that drug for a while when they get stereotactic radiation. Is there anything new on the horizon where patients can remain on that therapy and also have the SBRT?
Yeah, that's an excellent question. It's really based on safety and in side effects, right? Early on when TKIs were coming into the clinic and we're using stereotactic treatment, there were earlier observations that, for example, if we're going ahead to irradiate, say, a abdominal lymph node or a liver, and there was adjacent loops of bowel, that we did see enteritis or bowel inflammation with some serious consequences such as perforation and fistulas. And ultimately, we want to avoid that. So I know for ourselves in our clinic, we're very careful. We take into considerations in terms of the overall size of the lesion that we're going to be treating, its true proximity to these so-called critical structures before making a decision. Either we suggest the patient actually is on a break when we actually deliver those 3 to 5 treatments, or that it's okay to overlap. And a lot of that's a conversation with the patient, but also a conversation with a medical oncologist, with Garrick, saying, what do you think? And I don't want to say, because we're in the process of going through an analysis of our entire clinical experience, looking at not only oncologic outcomes, but also toxicity and side effects. But as a rule of thumb for TKI, for the most part, as we become more comfortable in the clinic and delivering stereotactic radiation treatments, that in some select patients that it's actually okay, but a lot of it's driven by the overall volume, how big that tumor I'm going to be irradiating, and the overall performance status, how the patient is feeling, and what the potential side effects may be, because there is documented toxicity when you combine targeted therapy with radiation treatment. At the end of the day, it's better to be safe than sorry, and I would rather be conservative, and generally I would advocate for a break, although sometimes if the patient does have rapidly progressive disease where those 7 to 10 days may potentially change the game, then I'd listen to Garrig's input and say, maybe we should just try to keep them on, right?
I have one last question for Dr. Kollmannsberger. We talked previously about some exceptional responders in patients. What can we learn from them, and how can we use that information to get better responses in a larger group of patients?
Yeah, we are actually very interested in these kind of exceptional responders on several levels. The easiest is basically you take the group of exceptional responders and you look and analyze how did they present, what did the tumor look like, where was the tumor, can we find a common denominator what makes them so special, and most of the time that only gives us very limited information, but then we can take blood and we can take tissue from their tumors. And we can do what Keith does, and we can analyze them. We can what we call sequence them, and look at the genetic makeup of these tumors, what kind of abnormalities these tumors have, and then we can go back again and say, compared to, in quotation mark, regular patients, what are the differences, and what can we learn from this? Can we learn something which would help us in the future to predetermine something? Or can we learn something, how we can increase the number of patients of exceptional responders? So there's a number of different research projects ongoing. We have one too. We have a collection of exceptional responders, and we look at the molecular level, and we look at how the tumors were genetically made up, and we're trying to figure out what makes them so special, because that would help us a lot in terms of determining why other patients may not respond, and how can we potentially circumvent that.
I think we're ready for questions from the floor. Maybe I can ask this of each of you. Where do you see new treatments and advances, 5 years down the road?
I'm very optimistic. I think the field will move at least partially or to a good part to this immunotherapy, to this new immunotherapy concept. And I think we will, for the first time, be able to actually increase the number of patients we cure, even if they present with metastatic disease.
As we were laughing earlier, I'm a radiation oncologist, and I'm a technological geek, as they would say. I know that in the clinic in the next 5 years is that, what's really has driven our ability to really deliver these high doses focused radiation with minimizing side effects is really our ability to see and treat the target clearly. And in the clinic or in our institution, we already have the next generation of radiation technology in-house, where we're going to be delivering radiation treatment simultaneously with MRI imaging, so we can actually see and treat and adapt the therapy on the spot in real time. Now, how is that going to integrate with what we're talking about today? It's really a different form of personalized medicine. It's basically custom sculpted radiation plans that your patients are receiving already, but even to the next degree, nth degree, to a higher level, that at the time of delivery, it's customized at that time, at that split second that we're actually turning on the radiation beam. Now, where's it going to look in the next 5 years? Yeah, it's going to be integrated with targeted therapy and drug therapy. Right now, in the next 2 to 3 years, like I mentioned, we're going to get a readout in terms of the safety of combining radiation or cytoreductive with drug therapy. And then in 5 years, I think we'll be seeing some of the next phase studies to look at the sequencing. We figured out the sequencing for the drug. Now we're probably going to need to figure out the sequencing of where to integrate the stereotactic treatment.
Or the combination.
Or the combination of the two. And that's where I see the next 5 years. And then certainly for primary treatment, there'll be further studies and evaluation, both not only in terms of the effectiveness, but also cost-effective analysis, and how is that going to work in terms of curing patients with non-metastatic disease. So I think there's going to be further integration between all the disciplines. For any patient that's coming in the clinic, I envision that we'll continue, at least in our institution, and certainly not only in the educational centers, but also bringing in places that have a lower volume of patients, the smaller communities, so they have better access, so that we can actually have that conversation and dialogue, so that they understand that you're not working in isolation, but let's get an opinion from everyone medical oncologist, a urologic oncologist, and a radiation oncologist, how to best manage any given patient that comes to your clinic, whether it be a big center or a small center. And it's really going to be about translation of experience and knowledge on a greater scale.
Yeah, and I would absolutely agree with both Christian and William. Really, I think now we're seeing, again, the common theme here is improvements in our ability to do, combination therapy, improvements in technology. And on the genetic side, it's the same idea, the technology and the innovation is rapidly progressing. And now what we're going to see is the benefits of that investment into technology development. And I think over the next 5 to 10 years, we're going to see that trickle forward. And rather than simply getting sequencing information on a tumor, we're going to actually be able to understand, hopefully at point of care with some of the new technologies, what are those vulnerabilities. And I really think that in addition to that, there's going to be a lot more types of treatment. So, we've exploded this arm of immunotherapy, but there's still a number of different approaches that are coming through the pipelines now at the preclinical level, at the early clinical trial level, that I think we're going to hopefully start to see being applied to kidney cancer. These are things that have not traditionally been applied to kidney cancer. There's still a number of barriers with respect to CAR T cells and these antibody type therapies. But I think a lot of those obstacles are being actively worked on, and if we can bridge over a couple of them, then these are things that could be rapidly applied to kidney cancer as well. So it's an exciting time.